Okay, from the previous slide, we can talk about how does our number of susceptible people change. We lose some number of people from the susceptible category who move into the infected category, and that number is proportional to the current number of susceptible and the current number infected. And anyone who moves out of this category moves into this category, so we have the minus and the plus. And then from the number of infected, currently infected, we have some people move to the removed group, and so there's a minus here because they're moving out of this category, and a plus because they're moving into that category. Here's one way to formulate it in a spreadsheet, maybe starting with 99 susceptible people, 1 infected, and 0 removed people, or you could think of this as 99% of the population or something, to tally the number of new infections, the number of new removed, and then say subtract the new infections from susceptible, add them to infected, or so here I'm not formulating the delta values. I could have more columns out here to the right that didn't quite fit on a slide, which isn't the best idea for not putting them, but an actual delta S, delta I, and delta R. So that's what I'm going to do in Excel. So we could say let's have 99 susceptible people, 1 currently infected, and 0 resistant or removed people. And I have my infectivity constant here and my recovery rate. So my number of new infections is my infectivity times number of susceptible times number of infected. My number of new recoveries, or removed at least, is recovery rate times the number currently infected. And then delta S is negative new infections because they're moving out of the susceptible category. Delta I is positive new infections minus the number of new recoveries or removed. And then delta R is positive new recoveries. This way I'm not recomputing the number of new infections because I use it once here and once here, and then the number of new recoveries I use once here and once here. So I'm not having to compute something twice. Here I'm kind of doing the same thing, I'm computing it once, using it twice. Alright, and the number of susceptible is the previous number of susceptible plus delta S, and then I can just do the same basic thing for currently infected and removed, and need all those formulas again, and then just fill that down. So this is nice. The formula for new susceptible is very simple. The formula for new infected is also very simple, rather than having this formula trying to take into account 2 cells over here, for example. That's also nice in a calculus sort of setting where the time steps might not all be just 1 unit each. I'd want to multiply the delta S or delta I by the time step size, and here I could do that simply. In this case, I would need to multiply this whole expression, this part of the expression, by the time step size, but not that part. So this is also a little nicer that way. So you should go make a graph. I happen to have one handy here. And this is what we get. So the number of susceptible started near 100 and decreased, but then stabilized. The number of currently infected rose and then came back down as they got recovered or unfortunately passed away. And the number of people in the removed category rose and then leveled out. So here, not everyone ended up getting infected, which is good news. But it was about 70-some% of people eventually had been infected, so that's maybe not good news. So that's a basic SIR model. And we have some links here to free online epidemiology manuals in case you want to go reading all the really interesting stuff. What does our model not cover? So if we had vaccinations, people would move directly from susceptible to resistant, although some wouldn't work for everyone, so some people could still stay in susceptible for a while before getting infected. Some diseases you don't have immunity, so you can go back to being susceptible after being infected. Some diseases, transmissibility changes by time of year, either because of the biochemistry and the temperatures or because people are behaving differently. Or we could have a model where the worse the infection gets, the more social distancing people do, and that K value changes. You can have different phases of being infected, as we're hearing now with the coronavirus, where you can be contagious and spreading it, but be unaware that you are and still mixing with people accidentally. Or you could be sick but not yet contagious. That's maybe not quite so worrisome. What we're really seeing with the coronavirus issue is that this number of currently infected people is too broad of a measure. You have to think about how many people need hospital treatment. Of those, how many people need ICU treatment or ventilators. We also have to think about that transmissivity is different from the general population to each other versus infected patients to healthcare workers. If your healthcare workers are a limited commodity as they often are, then you might need to include a separate compartment to keep track of infections among healthcare workers, for example. Malaria is an interesting case because not only do you have to track how many humans are infected, but also how many mosquitoes are infected. Probably the same with other mosquito viruses like Zika or dengue. So the classic model for that is Ross McDonald. You might have noticed this is the same as my last name, but I don't think I'm related to that person. If it was a longer span of a disease, we might be also concerned about changes in the population size due to births or immigration or non-disease deaths. People still get hit by garbage trucks every now and then, or don't get to the disease and end up getting cancer or heart disease. So you can make these models really, really complicated if you want. Another thing we haven't done here is models in different regions, maybe county by county or city by city, and I have separate software to show you that, so I'll do that in another video.